Welcome to the UT Healthy's Texas Virtual Education Series. Today's presentation topic is TAVR, Aortic Valve Replacement Without Surgery, featuring Dr. Thaddeus Tollison, board-certified cardiologist at Tyler Cardiovascular Consultants.
Today we're going to talk about what we call TAVR, transcatheter aortic valve replacement, which is basically valve replacement without having open heart surgery. And if someone would have told me 30 years ago when I started this journey that we'd replace someone's aortic valve without opening their chest and doing it in the traditional fashion, I wouldn't have believed it. But the technology is advanced to the point, like it has in a lot of fields of medicine, where this is now a reality and commonplace here at UT for patients. So before we talk about it, let's take a step back and talk about what is aortic stenosis. So people hear about valves in their hearts. Valves are like doorways in your heart, and your aortic valve it's similar to the front door of your heart. Every time your heart beats, your aortic valve opens, lets the blood out of your heart to the rest of your body. Aortic stenosis is a condition where the heart valve, through wear and tear primarily as we age, instead of opening all the way, it only opens part of the way, and then it narrows further and further, and so that's aortic valve stenosis, or narrowing, and we commonly just call it aortic stenosis. So when you hear that term, that's what it is. What typically will happen, though, is that as that valve narrows, harder for the heart to pump blood out, harder to get blood and oxygen to the rest of your body. So some of the symptoms that people commonly come in and complain to us of is they get more short of breath when doing normal activities that they could do without any symptoms in the past. They get tired more easily, and sometimes they'll get pressure, tightness in their chest, similar to what people get with blockages that end up leading to heart attacks and so forth. And so you can see that some of these symptoms people will write off to, well, I'm getting older, age-related, I'm not as spry as I used to be, and so forth. And we come to find out a lot of times that these conditions, that because they're insidious in onset, or they come on very slowly and gradually, that people don't recognize them until they're further down the road. There are different causes of aortic stenosis, but the vast majority of Americans it's what's called senile calcific aortic stenosis, which is a fancy term that means it's age-related. Your valves are like everything in our body; they wear out with age, and so it's primarily an age-related phenomenon. So we've talked about the symptoms. Why is aortic stenosis dangerous? Well, if you compare it to cancer, if you compare it to metastatic cancer, the long-term outlook once you develop aortic stenosis is actually worse than it is with many cancers in terms of survivability over time. And so once patients start having symptoms, the average lifespan without treatment, without aortic valve replacement, is somewhere between 6 months and 24 months. And so what we tell patients, or what I counsel patients with, if they develop this, as long as they're not having any symptoms, it's safe to watch. It's similar to somebody saying your knee's worn out. Well, if it's not bothering you, you're not going to have it replaced. Aortic stenosis is similar in the sense that if it's not causing any symptoms, it's generally safe to follow it and to keep an eye on it. Once you develop symptoms, the clock starts ticking, and it's time for treatment if that's the option and that's the way that you want to go. As you might expect, it's a relatively new treatment for aortic stenosis. Traditionally, over the last probably 60, 70 years, the way that it's been treated is open heart surgery, open your chest, take the old valve out, surgeon puts in a new valve. It's a life-saving operation, but it's obviously a very big operation. It's open heart surgery, heart-lung machine, in the hospital for a week, 6 weeks of recovery and not doing anything and so forth, versus being able to go in through your groin, similar to how we take stents up and open blockages and stents. It's about an hour procedure. Most people are in the hospital overnight only. They go home, and within a couple of days, they're back to their normal activity and so forth. So in terms of morbidity or how invasive it is on the body, it's obviously light years ahead of how we started this years and years ago. And so if the outcomes are similar, and I'll show you that in a moment, and the downtime, the discomfort, and the taking a break from your normal life can be minimized with no downside, it's a phenomenal treatment for the majority of patients now. So the technology it started around 2005 when we began to look at this concept and realize that, similar to how we instead of doing open heart surgery and bypass surgery, we could take stents up and open blockages with stents, and that technology progressed. It's the same pathway that you kind of see with TAVR or with aortic valve replacement. And by the way, TAVR just stands for transcatheter because we use a catheter in your artery instead of surgery. Aortic valve replacement, so TAVR or TAVR, and if you Google it, you'll get 5 or 6 billion hits on it because it's probably the biggest thing in anyone's career that's happened so far. So there were studies done early on that showed it was feasible to do, and then there were studies that were done that could directly compared it to aortic valve replacement via the traditional means of surgery, and all of those studies have shown that the outcomes are very similar, if not better, with TAVR in terms of things such as stroke rates, hospitalization rates, recurrence rates, and the only thing we didn't know early on was durability. We know that surgery done for aortic valve replacement, because it's been done for so long, you can expect a certain lifespan from these valves. We didn't know that early on because these TAVR valves have not been put in that long. We're now out far enough that we can confidently say that out to at least probably 11 to 12 years, these valves perform almost identical to surgical valves. And that's not surprising because in the setting of one of the valves, the valve that's primarily used by our team here is the same company makes the surgical valve and the TAVR. It's the same material, it's the same valve. The mechanism that we use to deliver it to the heart is just different. One's built to take up through your artery, and one's built to be sewn in, through open heart surgery. But the tissue, the production process, and so forth is similar and is done in a very similar way. So when you talk about what patients can expect, that's kind of how we talk to them. Another thing that's different is the whole approach to doing this is different than what you see traditionally when you go for a surgery, you go for a procedure and so forth. And that is, here at UT and like some other of the big places, we've developed this very collaborative team approach in terms of how we do patients or how we manage patients and convey this to them. And that is, instead of going in, if you have to have gallbladder surgery and the surgeon says you need gallbladder surgery and you talk about it and then you have it done, you meet with a team of doctors when you come in with aortic stenosis and you're considering having TAVR done. The procedures are all done, and this is an FDA mandate when we first started doing it, is they're all done with an interventional cardiologist and a cardiac surgeon together in the room. And that's been a nice thing here at UT because we've always collaborated with the surgeons, but now we work with them basically on a weekly or daily basis doing these cases together. In fact, almost 300 of the cases now have been done by myself, one of my partners, Dr. Brent Davis, and the heart surgeons here, Vivek Patel and Stephen Phillips. We've all done all of these cases together. But when you first come in, or someone first suspects or is diagnosed with aortic stenosis and referred to our comprehensive valve clinic here, they'll come in on the day of their consultation and they'll have several studies ahead of time so that we can determine, are they a candidate for it? Can we safely deliver a valve? And then we meet with them as a group and we talk about what are the best options for you. Is the best option open surgery? Is the best option TAVR? What are the risks of each one? What are the benefits of each one? What are your expectations? And then with the patient and often their families, we make a decision jointly in terms of what's the best option in this particular case. And when we say their families, it's their children, but you realize that most of the patients that undergo this are in their 70s, 80s, and maybe even in their 90s. Their children are in their 50s and 60s. And so we have a very open, transparent discussion in terms of what the expectations are, what are we doing, and what do we hope to accomplish, and what can they expect, not just from the procedure, but from the benefits of the procedure, and what are the risks involved in it. Once that's done, we convey that information back to their referring physician. We schedule a date for the surgery, and then they come in for the surgery. They'll come in the day of the surgery, have it. As I said earlier, most of them are in the hospital for about 24 hours, sometimes 48 hours if they're older or have other medical problems, and then they're discharged home, again, with no surgical incisions or scars and so forth. I'm going to show you a video, or I'm going to let you see a video to give you kind of an animated picture of what this actually looks like. You'll see here on the video in a moment an animated kind of description of what we do. So the catheter now is in the aorta, which is the large artery coming out of the heart that delivers blood to the rest of the body. The valve is taken up, it's miniaturized on a delivery mechanism, and then once it's in the aorta, We basically, for lack of a better term, assemble it, put all the pieces together on the catheter, and we do that so that it's smaller when we take it in. Once that's accomplished through a guide wire, which is the wire you see that's already been taken around the aortic arch and into the heart, we're able to, like a train track, we're able to drive the valve up safely through their aorta. You'll see here where it goes across their aortic valve. We very carefully take it across where the old worn out aortic valve is, and then very precisely we position the new valve, to where it needs to be. We then basically, for about 15 seconds, will stop the heart. And people say, well, why do you stop the heart? We stop it because if the heart's still pumping, it's going to push that valve backwards and forwards, and obviously you don't want that. So when we do that for a few seconds, we then deploy the valve. You'll see the new valve goes in. We don't take the old valve out. What happens is the old worn out valve is basically pushed out behind this new valve, and then your body endothelializes, or basically covers it, repaves that area, so that valve is not part of the hemodynamic or the blood system anymore. And then as it heals, you don't see it anymore. It basically is healed over there. You'll see here, looking from above down below, the valve, which has 3 leaflets, or 3, kind of like a set of French doors with three sides to it, begins working immediately. So it's a little more complicated than that, but that's essentially how it works. Who are candidates for this? We tell people that, there are 85, 90, 95-year-old people with this condition that if they didn't have it, they would continue to live normal lives. But once they develop this, as I told you before, the clock ticks on how long they can live. And even though they're healthy otherwise, almost no one would recommend open heart surgery for them, just because getting them through the surgery would be tough enough. But then the recovery or recuperation afterwards is more than most people's body will tolerate at that age. Whereas if you could fix the problem without subjecting them to the trauma of an open heart surgery, they could certainly do that. And so the way we kind of look at things is, if they're 90 above, they're considered high risk. Those are definitely people that we would consider for TAVR. If they are, and we think of those as the Betty White group of people. If they're in their 80s, so they're probably only going to need one valve, definitely TAVR is for them. And so we look at those as the Robert Redford type people. And then people that are in their 70s, they're less risky. They could probably have surgery, but as we mentioned before, the morbidity from the procedure and the inconvenience and the pain and recovery are so much less with TAVR that, again, it's the favored option. The studies have borne that out over bypass surgery. And whether this is right or not, this is the Mick Jagger group. I don't know if you're aware of this or not, but Mick Jagger actually had TAVR done. He had aortic stenosis. It was finally publicized that when he had this procedure, this is actually what he had. So the great rocker himself is he's not just a salesman for us, he's a client, so not us personally. But and then the only question are patients that are younger. Some people do develop this early on in life, and like anything else, and like a surgical valve, if it's put in, if it's a tissue valve, it has a lifespan. It's got a finite period of time before it will wear out. Younger patients that develop this often have a metal valve put in, because a metal valve will last your entire life. The problem with a metal valve is, because it's metal, you have to be on long-term blood thinners to keep blood from clotting on the valve. And so the question in the younger patients is, are they better having a TAVR and then maybe 15 years later they'd have to have it again, which is feasible to do. We do what are called valve-in-valve TAVRs, and we've done multiple ones of those. But the question is, if they're young enough, should they just have one procedure, be on blood thinners, and then not have to worry about it the rest of their life? And those are the patients that we have the more detailed discussions with, in terms of what are their expectations, what it is that they're looking for, and letting them understand not just this is what the procedure is, but you've got to think down the road with this group of patients, because they're going to be looking at something potentially to have to be done again down the road, or to be on lifelong blood thinners and so forth. And for some people that may not be a big deal. If they're very active, let's say they're sports enthusiasts, they do construction work, and they don't want the risk of being on blood thinners all the time, they may say, well, I'll take the risk, or I'll take the choice of having to have a second procedure 10 or 15 years down the road, as opposed to being on blood thinners. And that's a personal decision for each patient. And so our job is to give them all of this information and help them come to a decision that best fits their circumstances. Okay. As we move forward, I mean, this is the dawn of a new era in terms of how we treat structural or valvular heart disease, specifically here at UT. And we've really sort of developed this whole concept of, instead of meeting with the doctor in his office, we meet as a team of physicians and health caregivers and go over everything with the patient and really have a very open, honest, frank discussion with them with all transparency in terms of, these are the risks and benefits of each of the options that you have. Let's talk to you, get to know you well enough to see what's important to you, and then help you make a decision that's right for you. And that's going to be different in every person, and you don't know that till you meet each person. But our responsibility is to give you all of the information, to be honest about what you can expect from each one, and then to help answer questions to let you make an informed decision about what's right for you in your particular situation. So that shared decision making is us as the multidisciplinary team, and it's the whole concept of what we now call a heart team. And that's our whole group looking at all of this, as well as all of the imaging studies and stuff that you have to help you decide what's best for you. The whole paradigm, as I mentioned earlier, has really shifted, and you'll see on the slide here when we talk about not just the procedure itself being less invasive. You don't need cardiopulmonary bypass. You don't have to be on a ventilator long term or anything. There's no sternotomy, which is the midline incision where we crack your chest to do the surgery. In terms of risk, we've shown that there are significantly less risk in terms of, there's a lower overall mortality. Transfemoral means going through your femoral artery, which is the artery at the top of your groin, which that's how we go up with stents primarily, and that's how we go up with a TAVR valve. There's a lower risk of stroke, and there's a lower risk of new onset atrial fibrillation, which is the most common heart rhythm abnormality seen in cardiology. There's less bleeding risk because obviously we're talking about very minimal invasiveness in terms of how the valve is delivered and so forth. So a lot of benefits with the same outcome that's been shown in the studies between surgery and this. And so, and then as you look in terms of how do people do early on, obviously, instead of being in the hospital for a week or so after surgery, we're talking about an overnight stay in most people, faster return to their normal life, especially as we're doing this in younger patients now, better quality of life because the rehabilitation from this is minimal compared to rehabilitation from open heart surgery. And then long term, in terms of how these people do, as I mentioned earlier, if they have to have a second procedure, because this valve can wear out just like the original valve did, the way I explain it to patients is, if the valve that God gave you wears out, our valve's probably not going to perform better than that. So it will at some point that has the potential to wear out. Now we're out to, like I said earlier, about 11 or 12 years, and they're at least as durable as the surgical valves, which is what we've wanted to see. Most of us feel like that'll continue on that trend, that there will be at least as good, if not better, in terms of long-term durability. But the honest answer is we don't know, because we're not at that time point yet. But we've seen that so far. And then obviously, because it's a tissue valve, it's not a metal valve, you don't have the need for long-term blood thinners, for things like that have their own set of risk and consequences with them as well. So we kind of boil it down to it in our field of work, and the way that we approach it is, it's all about the patients. Our job as cardiologists, cardiac surgeons, and so forth is to give the patients all of the information. It's impossible to walk in and understand this whole concept. And so our job is to explain it in terms that people understand and that make sense to them, to explain the benefits of it, to explain the risks that go with all of the procedures, whether it's surgery, whether it's TAVR, whether it's choosing not to do anything and follow this, but to give patients the information so that they can make an informed decision, and they can make a decision that's right for them individually. I'm not going to say that I condone all of our social activities here, but the point of this is we're seeing patients live into their 90s, not just living that long, but living well. I saw 2 patients in my office, earlier this week that were in their early 90s. They live independently, they drive, they do everything. And so if one of those patients develops aortic stenosis, and that's the only thing that's going to limit them or limit their life at that point, to be able to treat that situation and rectify it without them having to undergo open heart surgery or trying to rehabilitate from that, it's a nice thing to be able to do, because before TAVR, if someone like that came in, we really had no options for them. So being able to have an option for people like that, and now to come all the way out full scale and have an option like that for basically anyone, has really revolutionized how we treat valves in terms of that. And so our patients are always our point of care. That's always got to be the focus in terms of what we're doing. As we get close to the end here, we've had several questions that have been posed, and so let me, if you don't mind, take a couple of those. First question was, what's the valve made of? Great question. It's a tissue valve. So it's actually, people always talked about pig valves. Most of the valves used now that are tissue valves are actually, they come from cows, or they come from bovine pericardium, which is the lining around there. And as I mentioned earlier, the company that makes the surgical valves also makes the TAVR valves. So it's what you saw earlier in the animation is those leaflets that were opening and closing on the valve are actually made out of a real thin tissue on the outside of a cow's heart. And so they're made out of tissue, and because of that don't require blood thinners long term. Another question was, how long will the valve last before it has to replace? And we touched on this earlier. We know now, and the surgeons have always told people when they have an aortic valve replacement, most of them will say that somewhere 10 to 15 years is the average expected lifespan of that. And we know now that these valves perform pretty close to that, if not better. And so we're out to about 12 years and the valves still look really good. So we know out to there, and we expect that it's going to go on beyond there. And so we don't have any signals or any red flags that say that it would be any sooner than if you had open heart surgery. So you don't pay any price for a less invasive procedure in terms of long-term durability. Another question, is it safe to have an MRI or an X-ray? Short answer, yes. Whether you get a coronary stent to open blockages, whether you get a TAVR valve, you don't pay any price in terms of not being able to have an MRI, any kind of X-rays. You can walk through the airport screeners and you won't set off any of the alarms or anything. So there's really no downside in terms of anything of that nature, but good question. And then finally it says, when can I go back to normal activities or go back to work after TAVR? And again, mentioned it a little bit earlier, but let me expand on it a little bit. So the typical thing that we tell patients, and the typical way that it progresses, is after their workup, we'll set a date for their surgery. They'll come in the morning of surgery, have the procedure, and then the majority of them, number one, will go home the next day. And remember, they're not going home with surgical incisions. They're going to go home with a little nick in their skin that's about a half a centimeter. We put a stitch in below the skin, so on the surface of the skin, you don't see anything but a small line that heals on its own. Most people are up around, walking around that at the afternoon of the surgery. We make sure that they're doing well. We make sure they have no bleeding and so forth, and then they go home. And then we usually tell them a couple, 3 days after that, you can get back to your normal activity. And that's not even because of the valve. It's just because of where we go in. We want them to baby their leg for a couple of days so that they don't have any problems. And we typically do these on Wednesdays, so a lot of people, if they're working, people will return to work the next week. Certainly no reason that they can't if they otherwise feel like doing so. So I hope I've tried to point out to you, it's an exciting thing for us. It's exciting for us because we have a group of people that we could never treat before, that we really had nothing to offer for them if they were not good candidates for surgery, and that we've shown now through all of the clinical trials where it's been compared to open surgery that you don't pay a price for the less invasive procedure in terms of how well the valve does or how long it lasts. And so to be able to offer that to patients, the same long-term outcomes with a less invasive, minimally invasive procedure, to where there's not the pain, the discomfort, the time away from your life and your work and the things that are important to you, and letting patients get back to their normal lives as quickly as possible it's what it's all about, and that's what we enjoy the most of this. So I thank you for your time.